that year, 2016, 20 people younger than 70 years. India has a very high burden of acute coronary syndrome, studies showing a significant number of cases. And ST elevation myocardial infarction is a common presentation along with non-HTACs and unstable angina. In most countries, in Europe and Western countries, non-ST elevation ACS is more common than ST elevation, but in India, ST elevation is more common, and it has the highest burden of acute coronary syndrome in the world based on some epidemiological data generated from India. Patients with ACS in India tend to be younger, lower socioeconomic, and much higher rate of STEMI than in developed countries. My objective today would be to talk about indications of revascularization. Who needs to go to the cath lab? Not everybody with acute coronary syndrome needs to go to the cath lab. And then if they need to go to the cath lab to have angiography, do they need PCI, do they need cabbage, or they may be treated medically. What is the optimal initial antiplatelet therapy which continues to evolve? The strategy for multi-vessel disease which has changed really in the last 10 years. And I know Dr. Rajagopalan at some point will talk more about cardiogenic shock, but we'll talk briefly about acute coronary syndrome with cardiogenic shock and what do the guidelines say. We're going to start with a case rather than just a didactic presentation. So the first case is a 69-year-old male, history of type 2 diabetes mellitus, hypertension, dyslipidemia, multiple risk factors. Comes in with chest pain that started 2 hours ago prior to presentation. He is in moderate distress, hypertensive, blood pressure is 154 by 88, his tachycardia. He's got a few basal rales or crackles, KVP is mildly elevated. EKG shows sinus tach and a millimeter of ST depression inferolaterally. Initial troponin is 11, the normal for this assay is a high sensitivity troponin assay. Is 12 for men. An hour later, it's 29. Serum creatinine at presentation is 1.3. So the next best stage in this management will go for coronary CT, to an exercise ECG, to a coronary angio, or to a stress nuclear imaging. And with that, I'll ask the audience to respond. So most individuals went with invasive coronary angiogram, and let's look at the data. So there are multiple risk stratification tools, and ideally, instead of using the Gestalt, it's best to risk stratify these individuals with a risk score. You could use race, you could use TIMI. TIMI has a separate risk score for non-ST elevation ACS and one for STEMI. Both the European and the ACC guidelines give preference plus ticagrelor or aspirin plus prazolam. You need dual antiplatelet therapy. And then from anywhere from 10 days to a month, you could peel off and make it monotherapy, but initial therapy is always capped with aspirin ticagrelor or aspirin prazolam preferred over aspirin clopidogrel. With cabbage, we have no data on prazolam, so you can do aspirin ticagrelor or aspirin clopidogrel. And if you're just treating medically, then aspirin ticagrelor. The one exception where clopidogrel is still got the most robust data is after fibrinolytics, which is being used less and less. What is happening if somebody gets fibrinolytics, then we typically will take them to the cath lab within 3 hours, and they end up getting PCI. So the correct answer, as you correctly pointed out, aspirin plus prazolam was not an indication, was not a choice, so aspirin plus ticagrelor. And again, dual antiplatelet therapy is recommended for every patient. You may not need dual antiplatelet therapy for the entire 12 months, and there is some evolving data that going to ticagrelor monotherapy after a month or so may reduce bleeding with similar outcomes, but at least initially, dual antiplatelet therapy is the recommended therapy. Let's now look at another individual, a slightly older individual, 73-year-old female, history of hypertension, dyslipidemia, presents with chest pain that started 4 hours ago. She is in severe distress, blood pressure is low, 86/43. She is tachycardic, 114. Physical exam results crackles up to her scapula, very much lung flow, JBP is elevated. 12 leading kg shows sinus tachycardia, 3 millimeter ST depression in intralaterally. Initial troponin is 23, normal is less than 11 for women for this particular assay. An hour later is 73. Serum creatinine is 1.5. This is obviously somebody cardiogenic shock and in acute distress. So what is the next best step in the management? Should you do immediate coronary angiography with revascularization? Should you do immediate emergency angiography with revascularization plus place in Bella device? This is a microaxial intravascular flow pump. Should you do physicolytics? Should you do vasopressors to get the blood pressure up before you do anything, before we do angiography? Let's look at the audience response. And I think majority of you chose correctly to emergency vascularization and putting an impella. And let us now look at some of the data on what the course is. The guidelines say that in patients with acute coronary syndrome and cardiogenic shock, hemodynamic instability, emergency vascularization of culprit vessel like PCI or category indicated. This is based on Judy Hoffman's shock trial from many years ago. And this is irrespective of time from setting of onset. If you're shocking, take it to the cath lab immediately or within 2 hours, try to open up the blood vessel. Typically, what is happening is 30-40% of the myocardium is either stunned or getting necrotic or herniated and opening the pecker. As you mentioned, if you have multivessel disease, leave the non-culprit vessel alone because this is one group of patients. We mess around with the non-culprit artery and the patients do poorly.
Limited. So what is the sequence of events? Like you put first to do revascularization or the device or all together depending on the situation of that particular patient.
Right. Most of the time, if it is two operators, you could get access on both, typically for PCI, it's a radial access, and obviously for impella, most of the time it's a thermal access. If it's one operator available, sometimes during the daytime, two interventional cardiologists try to do this simultaneously, but if you have a choice, you always put in the impella first, quickly, to get the heart a little rest while it's working on revascularizing the culprit artery in a patient with cardiogenic shock.
What's the overall success rate in general?
Cardiogenic shock mortality is to 80%. And then with shock trials, we found that revascularization mortality rate is still like in the 60s. We're looking at mortality rate still 35 to 40%. So it's a very difficult, very high risk condition with very high mortality in hospitalization mortality. But we have come down significantly from 80% pre-revascularization to maybe 40% in most cities today.
So in good centers in imaging, MRI imaging, urgent MRI imaging, to see the hypertrophy myocardium or state myocardium.
You mean MRI, magnetic resonance?
Yeah.
We would never do an MRI in the setting of acute coronary syndrome. What we are beginning to do, I think there's a lot of interest in focus, point of care ultrasound. My cardiologist fellows have one in the pocket now, it's become so. So we'll quickly put a probe in, and again, ACC is fast as vectorized group. I didn't go into the imaging, but most of the time we're waiting to take the patient to the cath lab, we'll put an echo probe, take a look at mitral rigors, try to get an index of LV function, and try to get an idea of, one of the reasons.
Left mineral multivessel disease and say this is for AV. Do you routinely recommend intracoronary thrombolysis in such cases?
Intracoronary thrombolysis, first of all, thank you for the initial comments. As you said, that the duration and the time of low antiplatelet therapy is certainly evolving, and we talk about IV cannula in some of these patients who are not pre-treated. But somebody with left main, now if it is also left main, we do PCI, physical bifurcation left main. Also, in the setting of STEMI, we'll try to open it up. Intracoronary thrombolytics, we used to do a lot of intracoronary F6 which nobody uses now. You know, this was, we were part of the ACC launch when I was at the Cleveland Clinic. There is some data, but in the era of the more potent antiplatelet therapy, even using GP2B3 inhibitors, which is not used that much systematically, we're using less and less of intracoronary thrombolytics or intracoronary GP2B3A. And think Cindy Grimes produced some data that was in the prior era, more aspirin, triclopyrin, aspirin, clopidogrel, with the lower dose, 5-10 milligram intracoronary given with good results. It's mostly anecdotal. The smallest randomized studies haven't shown much benefit.
My question arises because majority of labs are not backed up by CABG or surgical units, and there is a lot of time lost transferring a patient to surgical unit and getting CABG. Vital period is lost, myocardium is damaged. What use of CABG after that?
Yeah, I mean, if you don't want to do stenting, you could do a balloon and open up the artery so that there is flow, so that the myocardium is preserved, and do a more semi-urgent CABG. You're correct. I mean, the best hospital CABG takes several hours just to mobilize. So opening the artery is critical in the setting of STEMI because it's typically a completely occluded artery. You can sometimes just pass in the wire, and you could send the patient. We have sent patients to the OR suite for wire so that there is flow. We have put an undersized balloon to make sure there is flow, but we want to revascularize, open up the artery as soon as possible, and not send to the OR suite somebody with a completely occluded vessel.
History of palpitations or edema, and no other major diseases. He's got a family history of hypertension and diabetes. His physical exam is unremarkable. He's not overweight, and he exercises regularly. His EKG and initial lab are unremarkable, and you decide to initiate antihypertensive medications on this visit, since you advised him about lifestyle recommendations on the previous visit, and his blood pressures are still fairly similar. So, what is your systolic blood pressure goal for this patient? Not necessarily what the guidelines say. We'll talk about that later. But when you're treating patients with hypertension like this, what would you treat them to? So less than 150, less than 140, less than 130, or less than 120 for their systolic health. And you can answer that. Okay, so less than 130 is what the majority would use, and then less than 140 for others. Very few would treat to less than 120 at this point. I will mention, by the way, that and we'll talk about the 2017 ACC-AHA guidelines, but the new ACC-AHA hypertension guidelines are going to be published later this year. So I wanted to mention that too. So the same patient, what would you treat his diastolic blood pressure goal to? So less than 90, less than 85, less than 80, or something else? You can answer now. Okay, so again, the larger proportion of you would use less than 80, next would be less than 85, and then less than 90. Okay, so let me first review the diastolic hypertension trials that we have. And I'm going to do this very quickly. Between the 1960s and the 1980s, there were a number of trials, but these were really the four major ones that looked at treating to diastolic goal. And diastolic pressure was what was focused on initially in the treatment of hypertension. There reasons I won't go into, but basically the physiology was thought to be the diastolic was more important. That turned out not necessarily to be the case. It certainly is in younger people, but not in older people. So the first study is the VA cooperative study, and that was the landmark study that proved that treating hypertension was beneficial. It was done in the 1960s, and it took a group of men in the VA within the United States who had diastolic blood pressures between 90 and 129. And realized at this time in history, virtually nobody was treating those people for their hypertension, even with diastolics as high as 120 to 130. And the goal was less than 90. And I won't show the results here, but it was very definitive, both for the group between 115 and 129. It didn't prove you shouldn't treat the 140, but after that, actually the guidelines continued. Even after those first three studies, guidelines continued to recommend less than 140 as the goal, and many do still today. Now, in 2018, we published the JNC8 guidelines. The committee had put it together, and I won't go into the detail as to why it didn't become the official guidelines for Metropolitan Blood Institute. They decided to get out of the guideline business, but it was still published. And in that guideline, we actually did recommend 150 as a goal for people over age 60 based on the data we had at that point. So that was 2014, not 2018. So in 2014, we did that knowing, as a matter of fact, many of us on the committee were participating in the SPRINT trial. So we knew that the definitive result for a lower goal would come out soon, but we thought it was going to be 3 or 4 years down the road. The SPRINT was supposed to be a 4 or 5 year study, and then it would stop early. So within a year of the JNC8 guidelines being published, the SPRINT trial was published. So I'll come back to that in just a minute. So in the meantime, in 2010 was the first study that looked at more intensive goals below 140 or 150, and that was the ACCORD blood pressure trial. And so in the ACCORD trial, you may remember, it was a pretty large trial, over 10,000. Everybody was randomized. They all had diabetes and hypertension, in either hypertension or dyslipidemia. And they were randomized to either intensive glycemia control with a hemoglobin A1C less than 6, or standard glycemia control with an A1C of 7 to 8. And much to our surprise, there was an increase in mortality with the intensive glycemia control. And so that part of the study, the glycemia part, was stopped early because of that harm. But the lipid trial, which I'm not going to talk about, and the blood pressure trial continued. So, sorry, something's missing here, but I'll focus on the blood pressure trial, which is right here. So the blood pressure trial showed a reduction in systolic blood pressure, compared a reduction in systolic blood pressure of less than 120 to less than 140, and in over 4,700 individuals. And we got a very nice separation of blood pressures, and it actually taught us how to do something. The overall outcomes were not significantly reduced. For the overall cardiovascular outcome, there was a 12% reduction in events. Because of the size of the study, that turned out not to be statistically significant. Now, the stroke rate was reduced by 41%. That was significant, but that was only the final results in the New England Journal in 2021. And I'll show primarily those 2021 results, but they're very similar to the initial results, just a little bit different in numbers. So here you see the difference in blood pressures. I didn't show that for ACCORD, but very similar. And so we got the systolic blood pressure goal, the 120 goal group down to around 120. The median was actually below 120. And then the standard group was about 135. And so we got a difference of 13.5 millimeters of mercury. The average number of drugs was only about one more antihypertensive medication in the intensive group, but the doses were often higher in that group as well. So just saying it's one more drug is a little bit simplistic, but most patients needed around 3 drugs or more. Some of them needed 5 or 6 drugs even. And As we showed in the initial publication, the primary cardiovascular outcome was significantly benefited. Here you see that it's a 27% reduction in cardiovascular events. It's 25% in the initial article, but really no difference between the two. You just have more events in the second publication. And so there's the primary outcome, the 27% reduction. If we removed heart failure, which some people criticized and said, oh, all the results because of heart failure, because you were using diuretics a lot, and it turned out that even taking the heart failure out, it didn't change. It was still a 25% significant reduction. And then you can see that many other outcomes were benefited, and including total mortality. And total mortality benefit when we first stopped the study in 2015 was a major reason to stop the study early, was having that benefit on total mortality. So that just summarizes that. And then I won't go into detail in the subgroups, but basically it shows that there was no heterogeneity. So all of the major subgroups we looked at, we pre-specified, there was similar benefit. Older age, younger age, above 75, and men and women, CKD or not, and so forth. Now, subsequent to the initial publication, there were a lot of other subgroups that were looked at, and by and large, virtually all of the subgroups showed a benefit or no significant differences when looked at. So what about adverse effects? I know that's a concern that many people have when treating people to 120 goal or any lower goal, 120 or 130. And it was very interesting that the overall serious adverse events were no different between the intensive group and the standard group. And so we didn't expect that. We thought there would be more. There were a little bit more in the accord intensive blood pressure group, even though there wasn't a big difference. What we did see, we looked at orthostatic hypotension. So we measured blood pressure standing at periodic visits and compared to sitting. And it turned out there was less orthostatic hypotension in the intensive group. Again, that was not really expected, even though we had a hint of that from the accord blood pressure trial. Subsequent to SPRINT, there have been other trials and a meta-analysis that looked at intensive goal studies and showed the same thing, that there's less orthostatic hypotension with the intensive treatment. Now, that doesn't mean that you can't produce hypotension that's too much in patients if you treat the blood pressure too much. My experience, our experience in SPRINT and otherwise, is that typically when you get the blood pressure down below 90 systolic is where people are starting to have symptoms of hypotension. Now, we did see some adverse events that we looked at a handful of events. We saw some that were
asymptomatic bacteria or history of infections. So technically, the guidelines say if you have a patient who's on an SO2 inhibitor and has an uncomplicated infection, you can continue the medication through the infection. You don't have to necessarily stop the medicine. But if they have reoccurring infections, this is where you would look into what are predisposing factors. Hygiene, uncontrolled diabetes, and so. But again, as I said earlier, sometimes patients, like this one actually, won't go back. So she refused. I tried to convince her. Maybe I didn't do a good enough job. She declined to start an SO2 inhibitor. So 6 weeks after her diagnosis, we did another echo. Now it is a little earlier to repeat the echo, but she was very anxious. I also have seen patients with pericardial cardiomyopathy get better quickly. So I was hoping that, I can give her good news if she's already gotten better. But you can see now her pictures are better, but the heart is not better at all. You can actually see it better because she's now symptomatically improved. We can get better echo pictures. And so LV function is still severely reduced. Sorry. So she feels much better. She's discouraged by persistent LV dysfunction. She's currently NYHA class 2. These are her vital signs. She's tolerating 3 of the pillars. I had switched her actually to sacubitril valsartan at some point, and she doesn't want an SO2 inhibitor. So what do you recommend to facilitate further left ventricular improvement? A, ivabradine, B, vericiguat, C, bromocriptine, or D, none of the above? this was great. So Ivabradine, this is kind of a trick question. So Ivabradine, your heart rate's 70, so I wouldn't do that. She's actually doing too well for the Vericiguat, because that clinical trial looked at patients far sicker, patients that were still having symptoms despite not improving on medical therapy. But I won't take the wrong answer given the choices that I gave. And bromocriptine, there's really very limited evidence for, but there is some evidence. So it's mainly, I brought this question up as more of a segue to talk about bromocriptine in pericardial cardiomyopathy. So this was a very small trial published in South Africa, which showed significant improvement over placebo, but just enrolling 20 patients. So in the United States, we are actually, and we are in my center in Kentucky, one of 50 centers to investigate this issue of randomizing patients to bromocriptine versus placebo. Bromocriptine is a prolactin inhibitor. So there's some data that prolactin pathogenesis, the breakdown products, the fragments of prolactin are part of the pathogenesis of pericardial cardiomyopathy. But there's really no hard evidence that it's a benefit. So the study is going to look at whether bromocriptine improves LVEF in patients with pericardial cardiomyopathy. Again, you cannot breastfeed on the medicine because it inhibits prolactin. So patients have to agree not to breastfeed to be part of the study. So she actually enrolled. It's a blinded study, so I don't know if she got the bromocriptine or placebo. And so I still follow her. This is her last echo. So it's not normal, but it's much better. She currently has no symptoms of heart failure, doing quite well. Still doesn't want to be on an SGLT2 inhibitor. I am going to get an echo probably in another 6 months. That's actually part of the study. They want to see patients out to 2 years. So again, this is a happy ending, but I kind of want to just hopefully highlight some of the challenges we have or some of the questions that come up with GDMT. And also I just wanted to throw in a bit of a teaching opportunity about bromocriptine, because I do know here in India you will see cases of pericardial cardiomyopathy. Some doctors do use bromocriptine, just because there is some limited evidence for it, and I don't think it's wrong. But in the U.S., we're at least trying to get patients enrolled in a clinical trial to help solve the question. So I do have another case, but I think I want to leave that for for the next talks in the other cities. I'll shorten this up so I can do the next talk, but I'll give it off to my next panelist.
They're often high in doctors' offices, and you hear that a lot. But she measures the blood pressure at home, and they usually are in the low 20s over 70s. She has no history of headaches, dizziness, syncope, chest pain, dyspnea, palpitations, or edema, and no other major diseases. But she has a family history of hypertension and dementia. She is concerned about developing dementia and asks if there is anything she can do to prevent it. Her physical exam is unremarkable, except that your staff get her blood pressure as 148 over 86. She's not overweight. She drinks an occasional glass of wine, and she exercises regularly. Her EKG and initial lab are unremarkable, and she is on no antihypertensive medications. So, which of the following would you do next? Repeat her office blood pressure with the aneroid manometer that's in your exam room, maybe on the wall. Repeat her office blood pressure with an automated manometer. Do nothing since her home blood pressures are normal. Start her on antihypertensive medication since her office blood pressure is elevated. C, do nothing since her home blood pressures are normal. So let me comment about each of these. First of all, don't use, and I don't think very many of you voted for this, don't use an aneroid manometer unless you know that it's either new or it's been calibrated within the last 6 to 12 months. We know that there are just springs and baffles and things like that, and they really get out of whack pretty quickly. And it's amazing how many people are using 20 or 30-year-old aneroid manometers, and you have to assume that they're not, because they're probably not. So B is repeat your office blood pressure with an automated manometer. That actually is the correct answer in my perspective. Using proper technique, and we'll discuss that briefly in a moment, unless you're certain your staff are following the correct technique. And that's very rare in the United States. I don't know if it is here, but I would say well over 95% of clinical settings don't measure blood pressure properly. So C, don't trust her home blood pressures initially. Instruct patient in proper technique. There are online videos, and have her bring her home blood pressure monitor in to compare readings. It's an automated monitor. That's actually correct also, I apologize. And you can compare with the ambulatory blood pressure monitor if available.
And I like to put this in terms of my own lifetime. So bile acid sequestrants came out around the time that I was born in 1973. And statins became more widely available and used around the time that I graduated from high school. And then lipoprotein apheresis around the time I graduated from medical school. Ezetimibe became more prevalent around the time my first daughter was born. And now we have incredible PCSK9 therapies. I'm very excited for this, especially in India where the prevalence of Lp(a) is so high. Okay, so our case study is a woman, 66 years old, South Asian, BMI of 30, with a history of hypertension, myocardial infarction, key past medical history here, so that we're in the secondary prevention world with a statin therapy, family history of premature ASCVD. She, like me, is a vegetarian and has a very carb-heavy diet, which is quite common in India, as you all know, and sedentary behavior, as I mentioned. In terms of lipids, her total cholesterol is 250, her LDL is 170, her HDL is 40, her triglycerides are elevated at 220, and her Lp(a) is also high at 55. So based on this initial assessment, what are some significant risk factors for ASCVD that stand out? And in addition to encouraging lifestyle modifications such as diet and exercise, what do you suggest? And let's start the timer now for the 10 seconds. So choice A is atorvastatin, choice B is bempedoic acid, and choice C is inclisiran. Okay, great. So the correct answer is atorvastatin at 40. And let's go over just briefly choosing the right statin. So there's 3 levels of statin intensity: high intensity, moderate intensity, and low intensity. And for those with clinical ASCVD, as our patient that we described now, falls into the high intensity statin group. And atorvastatin 40 is sort of the minimum statin that falls into the high intensity. My husband has high LDL, he's on atorvastatin 80. Statins are a very safe drug, as I'm sure all of you know. And there are some caveats with rosuvastatin for Asian populations, which I'll discuss in more detail tomorrow. So then the patient follows up 6 weeks later to monitor their lipid levels. In the meantime, ChatGPT about statins, and she reports increased physical activity and has a slight decrease in her BMI. Her LDL cholesterol has lowered slightly, but the patient reports muscle aches. And we can go ahead and start the timer as well now, and I'll just read out the answers. The most appropriate next step for managing the statin intolerance is to increase the atorvastatin to 80, switch to a different statin. Switch to a different statin. Excellent. Correct answer. And I want to go over some of these other options. So option D was plant sterols, and I understand there's a plant sterol in India called Flora Active. Please raise your hand if you or your patients have used Flora Active as a plant sterol. I see no hands raised. I think it's similar to Benecol in the US. I bought that for my husband and stayed in the very back of our refrigerator. And turmeric. So very important study about supplements. And this is on the left, the blue bar is rosuvastatin. It's just 5 of rosuvastatin, high intensity statin, compared to placebo, fish oil, cinnamon, garlic, turmeric, plant sterol, and red yeast rice. So our patients want to use all of those things, from fish oil to the left. The key message is that none of them lower cholesterol as well as statins in a head-to-head trial. This is an excellent trial called Sport that was published recently, and I cite it to my patients a lot, despite what they see on the internet and now with large language models. So the patient has stopped taking atorvastatin and is now on rosuvastatin, as we've recommended the second statin due to statin intolerance. After a few weeks, she continues to report muscle pains and cramps. You order a CK and the results are normal. So what is the appropriate next step for managing the statin intolerance? And you can start the timer now. Switch to a third statin, discontinue statin, and initiate ezetimibe. Add fiber, discontinue statin. Excellent. So this is the right answer, discontinue statin and initiate ezetimibe as the alternative. And this comes from ACC guidelines, and I've highlighted the box for you. We'll go over this in more detail tomorrow. So when you have a patient with clinical ASCVD or very high risk, like with an LDL greater than 190, and we'll talk a little bit more about this tomorrow, but LDL over 190 is highly suggestive of familial hypercholesterolemia. So first line ezetimibe and PCSK9s. And we'll talk a little bit more in detail about this tomorrow. I'm going to leave time for questions from the audience, so I'm going to wrap up here and we can discuss.
Aldosterone-related axis, perspiration, humidity, etc. have been touted as an additional regulator that needs to be considered in our part of the world when you're considering diuretic as a therapy. Overproduction of vasoconstriction, long-term high sodium intake. Foods are extra salt means anyway we are beyond 10 grams of salt in a diet, and then we are discussing whether we can take extra salt or not. Inadequate potassium, calcium intake inappropriate, activation of RAS, congenital abnormalities of resistance vessels, reduced production of vasodilators like prostaglandins and nitric oxide, presence of high metabolic syndrome, obesity, diabesity as they call now, and increased vascular growth factors and altered cellular ion transport constitute the various pathophysiological mechanisms across the spectrum of lifestyle, environmental, genetic risk factors which modulate why we tend to have high prevalence of hypertension. So this is one of the papers done by Cardiology Society of India, CSI Great India BP Survey as they call it. 1,80,000 patients, 33% women, mean age was 40 plus. Across 24 states across India, hypertension was defined as 140/90, or receiving treatment of hypertension with overall prevalence was 1 in 3 adults, 30%, 30.7% of it, 17.6% hypertensive, that means live in our part of the world. No wonder Sun Pharma is able to sell the pills, the number they were saying every minute as they were saying, which is unfortunate in the sense that the health burden is pretty enormous in our part of the world. Proportion of treatment, 88% actually received in the survey, and controlled blood pressure, but however only 41. We remember our preventive and social medicine days rule of 1/3. 1/3 are not diagnosed, 1/3 are treated, and 1/3 are treated to goal. But that doesn't hold true. This is now, fortunately, we have new data sets emerging, which is talking about hypertension treatment cascade in women. And in this NCD risk factor collaboration data published in Lancet, treated but not controlled with 24%, while 41% received treatment. That still constitutes in our part of the world more than one half not actually being treated at all. Again, when we look in males, this is where actually the patients who are treated but not controlled are fewer, which is 19%, and that's where gender disparity continues to be prevalent in in Asia, Southeast Asia as well. So 45% are diagnosed and 32% receive treatment, but treated with control are only very few.
As we talk about treating hypertension with medications, all the guidelines recommend also using lifestyle modifications. So in all of our large studies that we've done over the last 30 years or more, we've also encouraged patients to do lifestyle changes. They're not all easy. It's hard for our patients to do a lot of it, but often there's one modality that they may be able to focus on additionally. So it's good for us to communicate with our patients, see what we think, what we would recommend is best for them, and then what they, in turn, would want to do. So I'm not going to go into detail on this, but just to mention, these are the lifestyle recommendations that have the most evidence to support them. Weight loss, and of course weight loss with the, particularly with the GLP-1 agonists, is going to be more commonly seen and help our hypertensive patients. A healthy diet, and that's primarily the NASH diet. The Mediterranean diet, which is somewhat better for lipids, can be modified to be like the NASH diet. And so a combination of those two is actually a very good diet. Reduced intake of dietary sodium, and that's one of the more difficult things to do in our modern society, since people are often eating prepared foods or eating out, and it's very hard to reduce sodium in that context. Not sure what it is in India and the United States. About 70 to 80% of the salt that most Americans eat is from processed foods or from eating out. Enhanced intake of dietary potassium is not always added as a separate recommendation because supplemental potassium has not been very successful in lowering blood pressure. It may a little bit, but it's not recommended. And so really going back to a healthy diet and having a high potassium diet is a better way of lowering the blood pressure. And there are things in the NASH diet that we don't even have a full explanation for why they're beneficial. Things like low sodium dairy products. So, and then physical activity, as Dr. Sharma mentioned also, and moderation in alcohol intake, and he mentioned that as well. And that actually, I participated as chair of a large study in the U.S. looking at moderation of alcohol intake, and it actually is probably one of the easiest things to do here, because a lot of people who are drinking excessively don't realize that the amount that they're drinking may be unhealthy, and it's with a doctor's recommendation. They often will and can reduce their alcohol intake. So here are the oral medication drug classes that are currently used for the management of hypertension in the United States, and probably most of the world. And Dr. Sharma mentioned, I think all of these, but I'll just briefly go back over them. Diuretics, thiazide-type diuretics, and thiazide-type diuretics are what we have the evidence in randomized controlled trials for benefits. And they actually revolutionized the therapy of hypertension back in the 1950s and the 1960s, because